Welcome to our lesson today. In our previous lesson, we talked about the pectoral region and all its components. In our video today, we'll start with a fascinating fact. Experienced tailors know that our arms aren't perfectly symmetrical. That's why they stitch the right sleeve a little looser than the left. This subtle difference is rooted in our anatomy and daily habits, and it's a great segue into exploring the axilla or armpit, which is far more complex than it appears. Understanding the axilla's structure and contents is essential for both clinical practice and anatomical study. In this video, we'll break down the axilla's boundaries, its vital vessels and nerves, and the clinical significance of this unique region. Let's dive in and discover what makes the axilla so important. Axilla, commonly known as the armpit, is a parietal space nestled between the upper arm and the chest wall. Imagine it as a four-sided pyramid with an apex, a base, and four walls: anterior, posterior, medial, and lateral. The axilla is oriented obliquely, with its apex pointing upwards and medially toward the root of the neck, while the base faces downward. This unique orientation allows it to serve as a passageway for vital structures traveling between the neck and the upper limb. Understanding the axilla's layout is crucial for appreciating its anatomical and clinical importance. Study the axilla in detail. Proper dissection technique is essential. Place a rectangular wooden block under the neck and shoulder region of the cadaver to provide firm support. Abduct the limb at a right angle to the trunk and secure the wrist to the block. Begin by reflecting the lower skin flap until you see the posterior axillary fold, which is formed by the subscapularis, teres major, and latissimus dorsi muscles. Carefully clean away the fat, lymph nodes, and superficial veins to expose the deeper structures of the armpit. This methodical approach ensures clear identification of the muscles and vessels within the axilla. During dissection, two important muscles arise from the tip of the coracoid process of the scapula: the short head of the biceps brachii, which lies laterally, and the coraca brachialis, which is positioned medially. The pectoral muscles, together with the clavipectoral fascia, form the anterior boundary of the axilla. On the medial wall, look for the upper three intercostal muscles and the serratus anterior muscle. These anatomical landmarks are crucial for orienting yourself within the axilla and understanding its layered structure. Once the muscles are identified, the next step is to clean and trace the axillary vessels. The axillary artery and vein, along with their branches and tributaries, are key structures within the axilla. Carefully follow the course of the axillary artery and observe how its branches supply the surrounding muscles and tissues. This step is vital for understanding the vascular supply of the upper limb and the potential implications for surgical procedures or trauma in this region. Axilla's boundaries are defined by its apex, base, and four walls. The apex, also known as the cervicoaxillary canal, is directed upwards and medially toward the root of the neck. The base or floor is formed by skin and fascia and is convex upwards. The four walls, anterior, posterior, medial, and lateral, are formed by specific muscles and bones. Understanding these boundaries is essential for navigating the axilla during clinical examinations or surgical intervention. Apex of the axilla or cervicoaxillary canal is a triangular interval that serves as a gateway between the neck and the axilla. It is bounded anteriorly by the posterior surface of the clavicle, posteriorly by the superior border of the scapula and the medial aspect of the coracoid process, and medially by the outer border of the first rib. Through this canal, the axillary vessels, axillary vein, and brachial plexus enter the axilla, making it a critical passage for neurovascular structures. The base of the axilla is directed downward and is formed by the skin, superficial fascia, and axillary fascia. This floor is convex upwards, mirroring the concavity of the axilla itself. The base provides a protective covering for the vital structures within the axilla and serves as the area through which surgical incisions are often made when accessing the axillary contents. Interior wall of the axilla is primarily formed by the pectoralis major muscle, which lies in front, the clavipectoral fascia, and the pectoralis minor muscle. These structures not only define the front boundary of the axilla but also play a role in movements of the shoulder and upper limb. The interior wall is clinically significant, especially during surgical approaches to the axilla. Posterior wall of the axilla is constructed by the subscapularis muscle above and the teres major and latissimus dorsi muscles below. These muscles not only form the back boundary of the axilla, but also contribute to the movement and stability of the shoulder joint. The arrangement of these muscles is important for understanding the pathways of nerves and vessels that traverse the axilla. Medial wall of the axilla is convex laterally and is formed by the upper four ribs with their intercostal muscles, as well as the upper part of the serratus anterior muscle. This wall provides a protective barrier for the axillary contents and is significant in the spread of infections or tumors from the chest wall into the axilla. Lateral wall of the axilla is quite narrow because the anterior and posterior walls converge on it. It is formed by the upper part of the shaft of the humerus, particularly in the region of the bicipital groove, as well as the coraca brachialis and the short head of the biceps brachii. This wall is important for the passage of neurovascular structures and is a key landmark in surgical procedures. Axilla houses several vital structures, including the axillary artery and its branches, the axillary vein and its tributaries, the infraclavicular part of the brachial plexus, 5 groups of axillary lymph nodes, the long thoracic and intercostobranchial nerves, and axillary fat and areolar tissue. These components are embedded within the axilla, making it a crucial hub for blood flow, nerve supply, and lymphatic drainage to the upper limb. Axillary artery is a direct continuation of the subclavian artery. It extends from the outer border of the first rib to the lower border of the teres major muscle, where it becomes the brachial artery. The artery's direction changes with arm position. The pectoralis minor muscle crosses the artery, dividing it into 3 parts. The first part is superior to the muscle, the second part is posterior to it, and the third part is inferior. This division is important for understanding the artery's branches and their clinical relevance. First part of the axillary artery is enclosed in the axillary sheath, along with the brachial plexus. Anteriorly, it is covered by skin, superficial fascia, platysma, supraclavicular nerves, deep fascia, and the clavicular part of the pectoralis major. Posteriorly, it is related to the first intercostal space, the first and second digitations of the serratus anterior, and the medial cord of the brachial plexus. Laterally, it is bordered by the lateral and posterior cords of the brachial plexus, while medially, it lies next to the axillary vein. Second part of the axillary artery lies posterior to the pectoralis minor muscle. Anteriorly, it is covered by skin, superficial fascia, deep fascia, pectoralis major and pectoralis minor. Posteriorly, it is related to the posterior cord of the brachial plexus and the subscapularis muscle. Laterally, it is bordered by the lateral cord of the brachial plexus and the coracobrachialis muscle, while medially, it is adjacent to the medial cord of the brachial plexus, the medial pectoral nerve, and the axillary vein. Third part of the axillary artery is related anteriorly to deep fascia, the pectoralis major, and the medial root of the median nerve. Posteriorly, it is bordered by the radial and axillary nerves, subscapularis, and the tendons of latissimus dorsi and teres major. Laterally, it is adjacent to the coracobrachialis musculocutaneous nerve and the lateral root and trunk of the median nerve. Medially, it lies next to the axillary vein, the medial cutaneous nerves of the forearm and arm, and the ulnar nerve. Axillary artery gives off 6 branches, 1 from the first part, 2 from the second part, and 3 from the third part. These branches include the superior thoracic artery, thoracoacromial artery, lateral thoracic artery, anterior circumflex humeral artery, posterior circumflex humeral artery, and the subscapular artery. Each branch supplies specific muscles and regions of the upper limb and chest, making them vital for both function and clinical assessment. The superior thoracic artery is a small branch arising from the first part of the axillary artery. It runs downward, forward, and medially, passing between the 2 pectoral muscles. It supplies these muscles and the thoracic wall, playing a key role in the vascularization of the upper chest and shoulder region. Thoracoacromial artery branches from the second part of the axillary artery. It emerges at the upper border of the pectoralis minor, pierces the clavipectoral fascia, and quickly divides into 4 branches: pectoral, deltoid, acromial, and clavicular. Each branch supplies specific muscles and joints, including the pectoral muscles, deltoid, acromion, and sternoclavicular joint. Lateral thoracic artery is another branch of the second part of the axillary artery. It runs along the lower border of the pectoralis minor and is closely associated with the anterior group of axillary lymph nodes. In females, this artery is larger and gives off lateral mammary branches to the breast, highlighting its importance in breast vascularization. Anterior circumflex humeral artery is a small branch from the third part of the axillary artery. It passes laterally in front of the intertubercular sulcus of the humerus and anastomoses with the posterior circumflex humeral artery, forming an arterial circle around the surgical neck of the humerus. This artery supplies the head of the humerus and the shoulder joint. Posterior circumflex humeral artery is much larger than its anterior counterpart. It arises from the third part of the axillary artery and runs backward with the axillary nerve through the quadrangular space. It supplies the shoulder joint, deltoid, and muscles around the quadrangular space and gives off a descending branch that anastomoses with the profunda brachii artery. Subscapular artery is the largest branch of the axillary artery, arising from its third part. It runs along the lower border of the subscapularis muscle and supplies the latissimus dorsi and serratus anterior. It also gives off the circumflex scapular artery, which participates in the arterial anastomoses around the scapula. Branches of the axillary artery form important anastomoses with each other, and with branches from neighboring arteries, such as the internal thoracic, intercostal, suprascapular, and profunda brachii arteries. These connections provide collateral circulation, ensuring blood supply to the upper limb even if the axillary artery is blocked. This network is especially important during surgical procedures or in cases of trauma. Axillary vein is the continuation of the basilic vein and runs alongside the axillary artery. It receives tributaries corresponding to the branches of the axillary artery and the cephalic vein in its upper part. The vein lies on the medial side of the artery and becomes the subclavian vein at the outer border of the first rib. Unlike the artery, the axillary vein is not enclosed in a sheath, allowing it to expand during increased blood flow. Axillary lymph nodes are scattered within the fibrofatty tissue of the axilla and are divided into 5 groups: anterior pectoral, posterior scapular, lateral, central, and apical infraclavicular. Each group receives lymph from specific regions, including the upper limb, breast, and trunk. These nodes play a crucial role in immune defense and are key sites for the spread of infections or cancer. Axillary lymph nodes drain lymph not only from the upper limb, but also from the breast and the anterior and posterior body walls above the umbilicus. This extensive drainage area means that infections or malignancies in these regions can lead to enlargement or involvement of the axillary lymph nodes. Clinical examination of these nodes is essential in diagnosing and managing various conditions, including breast cancer. Infections in the axilla, such as boils or abscesses, are common due to the abundance of hair follicles and sebaceous glands. When an axillary abscess needs to be incised, the incision should be made through the floor of the axilla, midway between the anterior and posterior axillary folds, and closer to the medial wall. This approach helps avoid injury to the main vessels running along the axillary walls. The axillary arteries' pulsations can be felt against the lower part of the lateral wall of the axilla. This is clinically significant, especially in cases of trauma or surgery. To control bleeding from the distal limb, the artery can be compressed against the humerus in this region, effectively reducing blood flow and aiding in emergency management. Each spinal nerve is formed by the union of a dorsal sensory root and a ventral motor root. The dorsal root contains the spinal ganglion and enters the dorsal horn of the spinal cord, while the ventral root arises from anterior horn cells. These roots unite to form the spinal nerve, which then divides into a short dorsal ramus and a long ventral ramus, both carrying motor and sensory fibers. Only the ventral rami form plexuses, such as the brachial plexus. Brachial plexus is a complex network of nerves formed by the ventral primary rami of the lower forecervical C5-C8 and the first thoracic T1 nerves. It is responsible for the motor and sensory innervation of the upper limb. The plexus is organized into roots, trunks, divisions, cords, and branches, each with specific anatomical and clinical significance. Roots of the brachial plexus are formed by the anterior primary rami of C5, C6, C7, C8, and T1, with occasional contributions from C4 and T2. These roots join to form 3 trunks: the upper trunk C5 and C6, the middle trunk C7, and the lower trunk C8 and T1. Each trunk then divides into anterior and posterior divisions, which ultimately supply the anterior and posterior aspects of the limb. Divisions of the trunks join to form 3 cords: the lateral cord from upper and middle trunk anterior divisions, the medial cord from lower trunk anterior division, and the posterior cord from all 3 posterior divisions. Each cord gives rise to several important nerves that supply the muscles and skin of the upper limb. Sympathetic nerves for the upper limb originate from spinal segments T2 to T6, with most vasoconstrictor fibers coming from T2 and T3. Preganglionic fibers arise from the lateral horn cells, pass through white rami communicants to the sympathetic chain, and ascend to cervical and thoracic ganglia. Postganglionic fibers then join the nerve roots to supply the upper limb, affecting blood vessel tone, sweat secretion, and hair erection. Roots of the brachial plexus give rise to several important nerves: the nerve to serratus anterior long thoracic nerve, C5-C7, the nerve to rhomboids dorsal scapular nerve, C5, and branches to longus colli and scaleni muscles. These nerves play key roles in shoulder movement and stability. Branches from the upper trunk of the brachial plexus include the suprascapular nerve, C5-C6, and the nerve to subclavius, C5-C6. These nerves are essential for shoulder function, supplying the supraspinatus, infraspinatus, and subclavius muscles. Cords of the brachial plexus give rise to multiple branches. The lateral cord gives the lateral pectoral, musculocutaneous, and lateral root of the median nerve. The medial cord gives the medial pectoral, medial cutaneous nerves of arm and forearm, ulnar nerve, and medial root of the median nerve. The posterior cord gives the upper and lower subscapular, thoracodorsal, axillary, and radial nerves. Each branch has specific motor and sensory functions in the upper limb. The axilla is clinically significant due to its abundant hair follicles and sebaceous glands, making it prone to infections like boils. The axillary lymph nodes are key in diagnosing infections or malignancies in the upper limb, breast, and trunk. Palpation of these nodes is a routine part of clinical examination, especially in breast cancer screening. Erb's paralysis results from injury to the upper trunk of the brachial plexus, often at Erb's point where 6 nerves converge. Causes include birth injury, falls, or anesthesia mishaps. The main nerves involved are C5 and C6, affecting muscles like the biceps brachii, deltoid brachialis, and brachyradialis. The arm hangs by the side, adducted and medially rotated, with the forearm extended and pronated, a deformity known as policeman's tip hand. Erb's paralysis, several movements are lost: abduction and lateral rotation of the arm at the shoulder joint, flexion and supination of the forearm, and the biceps and supinator jerks. Sensation is lost over a small area below the deltoid. This condition highlights the importance of the upper trunk of the brachial plexus in upper limb function and the clinical consequences of its injury. Lump's paralysis is caused by injury to the lower trunk of the brachial plexus, usually from undue abduction of the arm. The main nerves involved are T1 and C8, affecting the intrinsic muscles of the hand and ulnar flexors of the wrist and fingers. The result is a claw-hand deformity, with hyperextension at the metacarpophalangeal joints and flexion at the interphalangeal joints. Sensory loss, and in severe cases, Horner's syndrome may also occur. The T1 nerve root is injured proximal to the white ramus communicans. Horner's syndrome can develop. This includes ptosis.